Hi and welcome everyone. We are continuing our interview with RT Joe here, starting with the MV setting questions. Okay, so now we're moving to the third part, which is mechanical ventilation settings questions. And the first question we have here, a student is asking, I'm still confused on how to fix my patient's pH if it's not on the normal range. What settings that I have to fix to put my patient's pH in the normal range?
Well, first of all, you have to understand what's causing the abnormal pH. There's only two things. It's either a metabolic problem or it's a respiratory problem. If it's a respiratory problem and your CO2 goes up, then your pH will go down. And in that case, you need to increase your minute ventilation to get the CO2 down. That will cause the pH to come back up into normal range. Now, how do we increase minute ventilation? Two ways. You increase tidal volume or you increase respiratory rate. That's it. Now, if your CO2 is low and it's causing your pH to be high, then now we need to decrease minute ventilation because our minute ventilation is too high. It's causing our CO2 to go too far down. So what we need to do here is we need to decrease minute ventilation. You can do that by decreasing rate or decreasing tidal volume. Both of those will decrease your minute ventilation. Your CO2 will climb back up into normal range and your pH should come back down into normal range. Now, if it's a metabolic problem, you have to understand how are we going to help compensate for this metabolic problem. And it's something that we don't always do. But if you have somebody who comes in with, say, a diabetic ketoacidosis and they're very, very acidotic, then one of the things we can do to help get that pH up into normal range or at least closer is we can hyperventilate our patient. Now, this person has a low pH because they have a low bicarb. If we blow our CO2 down by increasing minute ventilation, then our pH will come up. The problem is still the diabetic ketoacidosis. But with the mechanical ventilator, we can help fix the pH in the short term while insulin is given to help correct the DKA. Okay? So I hope that makes sense. Good question.
A student is asking, if I increase the respiratory rate, what will I change in the ABG result of my patient?
If you increase the respiratory rate, then you're going to increase minute ventilation. If you increase minute ventilation, you will decrease carbon dioxide. If you decrease carbon dioxide, you increase pH. That's your answer. Increased rate equals increased minute ventilation equals decreasing CO2 equals increasing pH. That's how it'll affect your ABG.
Okay, so moving on to another question. We have a student here asking, can you please talk about alarm troubleshooting? And what should I do first? And how can I fix the problem faster? Because he or she said, every time I hear an alarm, I would be in a rush trying to find a way to fix the problem. And that makes me nervous and not able to think well.
So here's the key. First of all, there's lots of alarms that you need to understand. But the key is to always start at the patient. Stop looking at the ventilator screen. Obviously, read what the alarm is. But let's say you get an alarm that says low inspiratory pressure. You get your low pressure alarm. Well, things that cause a low pressure alarm are leaks. So where's the leak? Well, chances are it's probably at the patient's endotracheal tube cuff. Now, if you start back at the vent, you're going to have to work all the way to the patient before you find this leak. But if you start at the patient, you will find it quicker. Okay? If you're getting an alarm that says high peak pressure alarm, again, start at your pressure. Look at your patient. Take your stethoscope and listen to auscultate them. Do you hear a bunch of coarse crackles? Maybe they need to be suctioned. Maybe you see the patient biting on the endotracheal tube and then work back from there. Maybe there's a bunch of water in the circuit. So always start at the patient and always work back. If you get an alarm that says apnea, look at the patient. Are they breathing? Maybe they've become disconnected. So I can't break down all the different troubleshooting alarms, but if you always stay calm and start at your patient, most of the time it'll lead you to the problem.
A student is asking, I heard from some RTs that the plateau pressure is not accurate in the ACPC mode. For example, she said, if an ARDS patient on the ACPC mode and his plateau pressure is 35 cm of water, it is okay to increase the PEEP and let the plateau pressure get higher because the plateau pressure in this mode is not accurate. Her question for you is that true or not?
It's not so much that it's not accurate, it's more of a fact that it's not a true reflection. And here's why. If you have a patient with a plateau pressure and pressure control of 35, it's because their inspiratory pressure is set on 35. You see, the plateau pressure and pressure control is controlled by the inspiratory pressure setting. It's the way it works. The pressure increases to the inspiratory pressure and holds for a set I time. Now, if you do an inspiratory pause at the end of that I time, guess what? The vent says, okay, I'll keep holding this pressure. And so in pressure control, your PIP and your plateau, your peak inspiratory pressure and your plateau pressures are the same. This is different than when you're in volume control, where you put in a set volume, you allow that volume to be delivered, and then you do an inspiratory hold. When that volume stops moving through the airways, you will see a true reflection of alveolar compliance. And so, is it inaccurate? No, it's just what's set. I think the point here is that it's controlled, but it is definitely different than volume control. And so there is a point to be made. You know, this is a tough question, because you can't say that it's inaccurate, because it is still a true reflection of alveolar pressure, because alveolar pressure is defined by the pressure in alveoli when flow ceases, without flow. Well, this happens in pressure control. The pressure goes up, it achieves the pressure, and then it holds the pressure open. So it is a plateau pressure, but it's just not an accurate reflection. I think a better way to say it is it's not an accurate reflection of alveolar compliance. So, good question.
A student is asking, what is the difference between PEEP and plateau pressure and airway pressure?
Good question. Peak inspiratory pressure is the maximum pressure reached during the inspiratory phase. So that's peak inspiratory pressure. This usually happens at the end of a volume control breath, or if you're in pressure control, then it's a setting, and so it's what's set. But it's going to be the highest pressure. PIP is a result of a tidal volume or gas moving through the airways and against the compliance of the alveolar tissue. Now, plateau pressure is the slight drop you see from peak inspiratory pressure down to plateau pressure when you do an inspiratory pause. Now, when you do the inspiratory pause, there is no air moving. And so plateau pressure is solely a reflection of the alveolar compliance. So if you want to assess airway resistance, all you have to do is see the difference between your PIP and your plat, because that takes out the pressure that is related to the alveolar compliance and leaves you the difference in those pressures with just the airway resistance being notable. Okay, and then mean airway pressure is the average airway pressure amongst all of the pressures in the airway throughout all of mechanical ventilation. So those are the key differences between PIP, plateau, and mean airway pressure.
Okay. A student is asking, how can I calculate the acceptable auto PEEP, and how can I resolve the auto PEEP if I had to?
So I think the key here is that we basically don't want any auto PEEP. If you have a small amount, I guess it's okay depending on your patient's disease process. So your patients your COPD or emphysomatics, obviously they may have a little bit of auto PEEP, but in general, you want your auto PEEP to be minimal. How do you fix auto PEEP? Well, one, you have to shorten your I time, or you have to lengthen your E time. So your expiratory time has to get longer, which means you can shorten your inspiratory time, or you can make your total cycle time longer. Your inspiratory time would stay the same, but your expiratory time would get longer. Let's say you took somebody from a rate of 10 to a rate of 6. Well, at 10, the vent's giving a breath every 6 seconds. When you drop it to 6, the vent's giving a breath every 10 seconds. You haven't adjusted or changed I time, but you've gained 4 additional seconds that will be going on to the end of your expiratory time. So those are the key ways. Now, how do we make I time shorter? Well, we give a higher flow, which will deliver the breath faster. We give a smaller tidal volume, which will also decrease your I time. Now, typically, you don't want to give a smaller tidal volume because you're going to change your blood gas. You're going to alter your minute ventilation. So that's not typically the best starting point. Now, if you're in pressure control, you just simply turn your I time down, because pressure control is a time cycled mode of mechanical ventilation. So you can just drop your I time down, and that would give you a longer E time. When it comes to total cycle time, again, changing your rate will change your total cycle time. This is why you always want to be careful anytime you have an obstructive lung disease patient, such as asthma, COPD, emphysema, bronchiectasis, cystic fibrosis, any of those patients. You want to be careful. When you start getting into rates up in the 20s, your total cycle time is now 3 seconds. And that is not very much time to get a breath in and a breath all the way out with our obstructive lung disease patients. So you want to be mindful of that as you take care of those patients.
Okay, so we're moving on to the fourth part, which is MV waveforms questions. And the first question we have here, a student is asking, is it enough to assist the patient on the ventilator from the waveforms?
Absolutely not. Nothing is enough to assess the patient on any one thing. So are waveforms very important? Sure. Are they the only things you should assess? Absolutely not. Waveforms can tell you lots of things. I'm going to go ahead and answer this next question, which is asking what kind of signs can you see? What do the waveforms tell you about your patient, if it's the right mode or if you should change something or not? So here's the value that waveforms give you. First of all, you can see on your pressure waveform if your patient is triggering the vent. You can see if the patient is trying to trigger the vent, but it's not triggering. And of course, you can see the difference in your PIP and your plateau. We'll talk to you about airway resistance. And you can also see the difference between your plateau and your PEEP to assess driving pressure. Now, those are just from the pressure waveform. Now, when you look at the flow waveform can tell you if your patient is air trapping or not. If the flow waveform does not return to baseline, then your patient is air trapping. When you look at the volume waveform, if it's not returning to baseline, then your patient may be air trapping, but you may also have a leak present, or you may have a leak present. So you have to ask yourself, if your volume waveform is not returning to baseline, then you have to ask yourself, is my flow returning to baseline? And if the answer is yes, then your patient has a leak. If your flow is not returning to baseline, and neither is your volume, then your patient is air trapping. And you can solve that by what I was talking about earlier about auto PEEP. Increasing E time by decreasing I time and giving your patient more time to exhale.
All right, Mr. Joe. So we got to the end of this interview. I want to thank you for giving us the opportunity to learn from your knowledge and experience. I'm sure all the students who send us their questions appreciate your time and effort.